Hi class, welcome. So today what we're talking about is more physics. Just when you thought you couldn't possibly learn any more, here comes a little bit more. And this is just because, we don't really know what exactly is going to be on the test as far as, um, the details of the questions and so on, but we have to cover all of our bases, okay, and make sure we know everything or as much as we possibly can know prior to the exam. So here's our trumpet shaped sound wave. And we have already covered the different parts of it and what they're called. A couple things are to know that the diameter of the beam right when it leaves the transducer is the same as the beam of the transducer. So that means this measurement here, this diameter of the beam is the same as the diameter of the transducer. So these two match. When they get to the focal point, the diameter is reduced to half of what it originally it was. And then at the end of the near zone length, or at a distance of two near zone lengths, I should say not one near zone length, my apologies, at a distance of two near zone lengths, the diameter of the beam is equivalent again to the diameter of the beam as it left the transducer, or we could say the diameter of the beam is equivalent to the diameter of the transducer, because remember, these two here have the same diameter. So understanding the beam diameter is important at different parts. So it is important to know the beam diameter as the sound wave is leaving the transducer at the focus at two near zone lengths, which would be the far zone, and then deeper than two near zone lengths. Another topic that we're going to talk about is beam divergence. And so you should have a list of what factors determine by. On this list, you would have something like, what factors determine attenuation and frequency for a pulse wave transducer and so on. And so on that list, you would put now what factors determine beam divergence. But first, what is beam divergence? So beam divergence is the widening of the beam or the spreading out of the beam. So it is the opposite of convergence, right? So if I go back to this picture here, when the beam is getting tighter and more narrow as it is progressing towards the focus, right? So we're talking about the beam as it is progressing towards the focal point, it is converging, right? The sound wave is getting tighter and more narrow. And then after the focal point, the sound wave gets bigger in diameter or wider or spreads out, and that is called beam divergence. And so now we're going to discuss what factors determine beam divergence. The two factors that determine beam divergence are transducer diameter and the frequency of sound. And both of these are inversely related to beam divergence. So you're going to add this to your list. And then this is something that, all of those determined by factors on the list that we've, been accumulating, those are all something that you just have to memorize. Some of them are pretty easy to memorize and make sense. For example, attenuation to me makes perfect sense that, attenuation increases with an increase in path length or an increase in frequency. But some of the other ones, maybe like the bad physics one and so on, those are just more memorization. So this is also one that sometimes it makes sense to students and sometimes it doesn't. So let's look at how diameter affects divergence and how frequency affects divergence. So here's an example of how transducer diameter is inversely related to divergence. So when you have a small diameter transducer and you look at that sound wave, so whenever they're talking about the diameter of the transducer and divergence, you have to know that it's kind of opposite of what you would think, right? So a small diameter has a large divergence in the beam, and then a large diameter transducer has a smaller amount of beam divergence in the far field. And so we're always talking about the far field because that's where the beam diverges, right? Up until the focal point, the sound wave converges. So of course it always, when we're talking about divergence, we're always talking about it widening in the far field or in the Fraunhofer. And I remember this one simply because it's the opposite of what I think. I normally would think that a small diameter would have a small divergence and a large diameter would have a large divergence, but it is the opposite. And then also, we have to remember that anytime the sound wave is getting wider, it is going to degrade lateral resolution. So you might get questions on divergence and its association to transducer diameter. And then also any of those resolution questions, you got to be ready for them because there's a lot of them on the test. Here's an example of how frequency affects divergence. So in the top example, we have a 2 megahertz transducer, which is described as a low frequency transducer. And this low frequency transducer will have a large divergence. Again, anytime the sound wave is spreading or widening, it is degrading lateral resolution because lateral resolution loves or increases narrow beams. So when it's widening, it's actually degrading lateral resolution. And then here you have the high frequency transducer. In my example, I used a 20. And then for that 20, you have a small divergence. And so this is an example of how the frequency of sound affects divergence of the sound wave in the far zone. And this isn't just another way of looking at the same thing. So kind of, cutting out as much of the information and boiling it down to just what we need to know. So when we're talking about less divergence, right? So a more narrow beam, that has to do with a large diameter transducer or high frequency sound. When we're talking about more divergence, more of the widening of the sound wave, we have that's associated to small diameters and low frequency sound. So remember, if I go back a couple slides, not only do you have to know that divergence is inversely related to diameter of the transducer, divergence is also inversely related to the frequency of sound. You got to also know the relationship. You got to know whether they're inversely related or direct. And because the resolutions are so important, I just want to touch again on lateral and axial. All of them are important. Lateral, axial, elevational, temporal, contrast, spatial resolution. Feel like I might be missing some, but lateral and axial, most definitely, they're like the key players. I really like this chart of how they have the two types of resolutions kind of side by side for comparison. So I wanted to share this with you. Switching gears now and talking about hemodynamics, which is the study of blood, specifically talking about veins. So veins are thin-walled. They are comprised of three walls, tunica intima, media, and tunica adventitia. However, those walls are fairly thin, and because they are thin, they are also collapsible. So it is easy to compress a vein and completely collapse it, completely close the lumen, simply by exerting some external pressure. Just by putting pressure, either by pushing on the vein with your hand or with your transducer, you would easily collapse a vein because it has thin walls. When venous inflow increases during exercise, the shape of the vein changes. It goes from an hourglass shape to oval and then to round. The changes in shape allow veins to increase in blood volume with very little change in pressure. So let's take a look at that idea right here. So first we're going to take away when venous inflow increases during exercise. So they're saying during exercise, so when you are working out, there is an increase in venous inflow. So like blood moving into the veins, okay? So that means as you are exercising, there is an increased amount of blood being dumped into your veins, which then goes up your body through your IVC and to your heart. But even when you are exercising and there's an increase in venous inflow, there's very little change in pressure. So think about that. There is an increase in venous inflow. There's an increase in flow, right? So I want you to think about a vein like this. Okay, here's my vein. If I dump a large amount of if I have an increase of inflow, so like, or I could say an increase in blood volume, normally you would expect there to also be an increase in pressure inside of that vessel. However, with veins, that's not the case. There actually is very little change in pressure at all. And the reason that there is very little change in pressure in a vein is because the vein will simply just change shape. So it will expand in order to accommodate that large venous inflow or that large volume. And so let's take another look at that. So regionally, veins have an hourglass shape. This is the normal shape of the vein, so somewhat of a collapsed state. Again, when there is an increase in venous inflow, the vessel will change shape from hourglass to oval and then finally to round. The idea of this is written here in the corner. It says, even though the amount of blood volume increases, the pressure inside of the vein barely increases. This is because the venous walls are compliant or flexible. Remember, they are thin. They allow for large volume changes to occur with small pressure changes. So the main idea here, if you kind of don't know how to focus your thoughts, is there's a couple takeaways. So first of all, you have to know that there is going to be an increase in blood volume. So, there's going to be blood that's being dumped into this increase in volume, an increase in venous inflow, however it's described, right? A lot of blood being pushed or forced into that vein. That vein, you would think, would then increase the pressure inside of the vessel. However, you have to remember that veins are very flexible and compliant. And for that reason, they'll just simply accommodate that large increase in volume by changing their shape and changing their size and accommodating that large volume. So that vein will accept that large volume with very small pressure change simply because the shape of the vein changed. Arteries do not do this. This is a venous conversation. Next, we're going to learn about something called hydrostatic pressure. Hydrostatic pressure is the internal pressure of the vein. Hydrostatic pressure is defined as the weight of blood pressing on the inside of a vessel. Hydrostatic pressure. So again, if we look inside of a vessel, so here's our vein. Hydrostatic pressure is looking at how much weight is being placed onto the walls of this vessel from the blood that is inside of this vein. It has to do with the weight of blood, right? So the weight of blood, and it also has to do with gravity. So if you look at the second bullet here, it says hydrostatic pressure is measured above the level of the heart and below the level of the heart. So it has to do with gravity, and I'm going to show you an example. The units are mmHg, which is millimeters per mercury. To measure hydrostatic pressure correctly and accurately, hydrostatic pressure should be measured at the level of the heart. Pressures are accurately assessed when the measurement is made at the level of the heart. So when the patient is in the supine position, such as our little stick figure here, every part of this patient's body is on the same level of the heart because the patient is lying down. Therefore, the hydrostatic pressure that is measured everywhere in the body will be zero. For the SPI, you have to know what hydrostatic pressure is. You also have to know that when the patient is in the supine position and every part of the patient's body is on the same level of the heart, you have to know that the hydrostatic pressure everywhere that it is measured, so whether they measure, let's say hydrostatic pressure has to do again with the reason we are concerned with that is for blood pressure reasons, right? And so when the patient is in the supine position and all of the body's on the same level of the heart, regardless of where, let's say, the nurse were to take the hydrostatic pressure reading, taking it in the ankle or the chest or the top of the head or anywhere on this patient, it really wouldn't matter because the entire patient's body is, in a horizontal line on the same level as the heart. And that is why the hydrostatic pressure everywhere is zero. And whatever measurement is measured on this patient is the patient's true circulatory pressure. So actually, if you've ever been to a doctor's appointment and your blood pressure reading was abnormal, they may have taken it again. Usually it's too high, but whether it's too high or too low, they took your blood pressure and it's still abnormal. Sometimes what they'll do is they'll have you lie down for a few minutes and then take your blood pressure reading, because when you are again in the supine position and your entire body's at heart level, whatever measurement is measured while you are in the supine position is considered to be your true and accurate circulatory pressure. Okay, but now let's talk about hydrostatic pressure when the patient is in the standing position. So when the patient is in the standing position, the blood pressure readings that are taken above the level of the heart. So let's pause for a second and let's look at this picture for a second. If we're looking at the heart, again, anything at heart level is zero, like we mentioned before, millimeters per mercury, and any measurements that are measured at heart level are going to be true and accurate. However, if blood pressure readings are taken above the level of the heart, so anywhere above heart level, and they might give you examples like taking blood or pressures of the head, pressures of the neck, right? Anything about above heart level will be negative. Okay, so what does that mean? Negative. You see the negative sign here. It means that the measured pressure that you get because you measured above the level of the heart will be lower than or negative than the true circulatory pressure. If the patient is in the standing position and a pressure is taken anywhere below the level of the heart, so below the level of the heart, so anywhere in the abdomen, the pelvis, the legs, the knee, the ankle, and so on, will indicate a positive reading. And what that means, that what positive measurements mean is that the measured pressure will be higher than what is considered to be the true circulatory pressure. And so anybody who handles patients and requires routine pressure readings, they are aware of this. They know hydrostatic pressure is zero at the heart. It's going to be erroneously, don't forget the word erroneously. That means, wrongfully. Too high if measured below the level of the heart, and erroneously too low or negative if measured above the level of the heart. Moving on, it's also important to understand for the ARDMS SPI examination how breathing affects venous inflow. So here I have organized what happens to the various parts and pressures of your body during inspiration and during expiration. So during inspiration, that means when you're taking a breath in, your diaphragm descends, it moves downward. That means that there's an increase in pressure in the legs. Pressure decreases in the abdomen, and blood moves from the head into the heart. So after taking a quick look at that, I realized that there was a piece of information that was missing, and also I made a change to the pressure inside of the abdomen so that it could be corrected. So during inspiration, when you take a deep breath in, your diaphragm moves downward. If your diaphragm moves downward, it's increasing, it's pushing down on the contents in your abdomen, right? So think about where your diaphragm is. Diaphragm is the muscular structure, dome shape, that separates your chest, your thoracic cavity from your abdominal cavity. So when you take a deep breath in and the diaphragm moves down, it's moving down, pushing down on the abdomen, therefore increasing the pressure in the abdomen. So if it's pushing down on the abdomen and increasing the pressure in the abdomen, it's releasing the pressure, going to a negative pressure in the chest. You can't have pressure increase in both your chest and your abdomen at the same time. They take turns. Uh, the opposite goes for expiration. When you release that breath, your diaphragm moves up, ascends, and now it's going to shift the pressure onto the thoracic cavity. So now thoracic pressure increases and releases the pressure in your abdomen. Not only do you have to know this, so this is pretty easy if you just think of what the diaphragm is doing. Is the diaphragm moving down or is the diaphragm moving up? If the diaphragm is moving down, it's going to put pressure on my abdomen. If the diaphragm is moving up, it's going to put pressure on my thoracic cavity. But add another layer to that, and now think about what is more prominent as far as venous return. So when the diaphragm is down, right, during inspiration, you have an increase of venous return to the heart from the head and arms. So all of that upper blood from the head, blood from the arms, returns to the heart when the diaphragm moves down, right? And then when the diaphragm moves up, and now it's increasing the pressure in the thoracic cavity. I think I have another mistake here. I have abdomen instead of thoracic. So, okay. Then you have an increase in blood return from the legs. And so that's why you have that here. So add that extra layer to it. So if they ask you questions about, what's the blood return to the heart? Is it from the head and upper extremities or is it from the lower extremities? Then you would know which happens during inspiration and which happens during expiration. Okay, so we've talked about attenuation a lot um, in chapter 3, but now we're just going to add some more pieces of information about attenuation. So air has a very high attenuation rate. That is why, so if you think about what attenuation is, right, it's the weakening of our sound wave. It's a decrease in amplitude, power, and intensity due to absorption, reflection, and scattering. So our sound wave is getting weaker. Think about air. Is air our friend? Do we enjoy when there's air bubbles or gas bubbles in the patient? No, because the air will act as a high attenuator on our sound wave, right? Bone has also high attenuation rate. It has a high absorption rate. So I want you to remember, what are the three factors that lead to attenuation? Absorption, reflection, and scattering. Absorption is the dominant factor. It's the number one leading cause of attenuation. And specifically, they want you to know that bone has a higher attenuation rate than tissue. And I've mentioned this to you before, as far as, eating a chicken drumstick. The bone gets really, really hot. So do our bones. Our bones get hotter than our tissue does when we are getting scanned. Biological tissue, blood, urine, and amniotic fluid, they attenuate the sound wave very little. And that makes sense because we do scan tissues, we do scan blood, urine. You're going to do that in semester 5. Actually, scanning through a urine filled bladder is a blessing. And amniotic fluid is, again, fluid is our friend, air is not. Water causes almost no attenuation at all. And that's why it's so easy for us to scan through fluid-filled structures. We can scan through a urinary bladder. We can scan through all the amniotic fluid that the baby is floating around. It actually makes it harder when there is no fluid around the baby. And then muscles have a unique effect on the attenuation of the sound wave. If the sound wave is going against the strains of the muscle, it will attenuate the sound wave more versus strains that are going with the sound wave. So let me show you an example. On muscles, muscles have very dense fibers, muscle fibers. So I'm just going to draw a piece of uh, tissue here, and I'm going to say that these are the fibers that are holding my muscle together. That's why muscles have, that kind of dome or rounded shape, because their shape is held by muscular fibers. So if this is the muscle here and you're scanning and the sound wave is going the same direction as those fibers, it's going to attenuate less versus if the sound wave was going against, 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 against each muscle fiber. One of the SPI questions is they're going to ask you what the master synchronizer is. Well, even just like master synchronizing, to synchronize something means to make sure everything comes together collectively and works harmoniously, right? And so it is what organizes all of the proper timing and interaction of the various parts of the machine. So even if you've never heard of Master Synchronizer, it kind of sounds like a fake piece of the machine. It is not. It is a real component of the ultrasound machine. We've talked about Alera often as well, but this Alera principle is very important because you have to really understand that it's always protecting the patient's exposure. So if your image is too dark, the first thing that you should do is increase your gain and not increase your output power. Increasing the gain, remember, increasing the gain, you're just increasing the brightness of the echoes. And those echoes have already come out of the patient's body. Do what you want with them. They're echoes, they've already come out of the patient's body. They will no longer be harming the patient, regardless of how bright you make them. However, if the patient is too bright, the first thing that you should decrease is the output power. So the pulsar output. And that's because in that way you are decreasing the amplitude, power, and intensity of the sound waves that are going into the patient. And so that's what we want to decrease. We want to be mindful of how strong those sound waves are, because they are what is actually going into the patient, not the echoes. So it is okay to increase the brightness of echoes, but if your image is too bright, you should decrease the output power just to continue limiting patient exposure. And then here's a nice diagram or chart where you can kind of compare the two, because you will get definitely questions on this. It's really important for the ARDMS to ensure that they are working towards registering ultrasound techs that are going to promise to keep the patient safe. So you're going to get questions on this. Make sure you review this carefully. Another thing is on the side of your ultrasound machine, so on the side of your display, so if you can imagine you're staring at your ultrasound machine right now, maybe taking pictures of the abdomen or the carotids or whatever you're taking pictures of, and there's some buttons on the side of your display. So those buttons are usually a contrast and a brightness button. So this is what you are looking at. So the buttons would be on the side of the display and not on the keyboard that's in front of you. Contrast determines the range of brilliancies that you will see on the screen. Brightness determines the brilliance of the image. So range of brilliancies is contrast range of. And so whenever you hear range of, it's the contrast versus just determines the brilliance of the image would be brightness. And so these are just definitions. Just as a reminder, when we are talking about turbulence, if you can hear turbulence, so an auditory sound of turbulence, it's called a bruit. I'm also including the word murmur now. And then if you can feel the turbulence, so you can feel that chaotic blood swirling around in the patient's vessel, what you in the patient's artery, what you are feeling at that time is a thrill. One thing that your book focuses less on is the loss of energy. So if we think back at energy, I hope that you remember that it was Bernoulli that talked about energy, and Bernoulli's contribution to the topic of energy was in regards to stenosis. So what Bernoulli had told us in the past in chapter 5 of your Kremkow 10th edition books is he said that in times of a stenosis, there's constant energy. There's going to be constant energy throughout the stenosis. So that includes energy proximal to the stenosis, at the stenosis, and distal to the stenosis. However, the energy will change. It changes, but it remains constant. It doesn't go away, right? We don't lose energy, it just changes. However, what your book kind of doesn't focus as much on is what happens if your test does ask you specifically about the loss of energy. So it says as blood travels through the body, it can lose energy. And so I kind of put the note there, not talking about Bernoulli with the stenotic region, because if we kind of add what Bernoulli said, we may get a little bit confused. So I just want you guys to kind of work out of boxes, right? So we remember what Bernoulli told us, and he said that energy is constant, energy changes, but there is constant energy throughout a stenotic vessel or artery. So now we're talking about something completely different, right? We're closing that box and working out of another brain box, and we are now focusing on the loss of energy. And when your test asks you about loss of energy, you have to know about 3 types of energy loss specifically. So there's viscous loss, frictional loss, and inertial loss. Viscous loss has to do with the movement of a high viscosity fluid. So viscous loss, it says more energy is lost when movement of high viscosity fluid. So a high viscosity fluid that you could think of is honey. So that makes sense to me. If water is moving, it's going to lose less of its energy compared to honey that's moving. The thicker fluid will require a greater loss of energy. And that makes sense to me too. Thicker fluid, more energy is lost as movement is happening. Frictional loss, it says, occurs when flow energy, so when flow turns into heat. How did we get heat? Well, the same way we have heat in our body. So when you have flow in your body, you also have heat in your body. So when blood is pumping through your arteries, it is actually acting as a little heater for your body, and it's keeping you warm. If that blood stopped pumping through your body, what do you think would happen to your body? Your body would get cold, right? And so frictional has to do with the rubbing or the sliding of red blood cells across each other as they are going through the body. Also, the red blood cells sliding through the vessel and sliding against the vessel walls. So when you think of frictional loss, I just want you to either think of, so if this is the vessel, these little red blood cells sliding across each other is causing friction, but also those red blood cells sliding across the wall is also causing friction, which is losing energy. Inertial loss has to do with any changes that blood has to make, specifically changes in acceleration or deceleration. So remember that saying, objects at rest tend to stay at rest. Objects in motion want to or tend to stay in motion. Energy is lost when the speed of blood changes. Okay, so again, the speed changes. So any changes in speed, it doesn't matter if blood accelerates, moves faster, It doesn't matter if blood decelerates, moves slower. Change is hard. Change will make blood lose its energy. So even if blood is slowing down, decelerating, it's still a change. And change is just a little bit more difficult and requires some inertial loss. So these are definitions you should know. And I do not remember the word per word, but I mean, one has to do with the thickness of fluid, one has to do with sliding or rubbing or friction against, something. And then inertial, I know that inertia has to do with how hard change is, and I remember that saying that I told you a moment ago. So even though I don't remember these three definitions of energy losses, I think I can get it just by studying it a couple times and kind of making sense of it. One of the SPI questions is just making sure that you guys understand the difference in definition between speed and velocity. Speed is defined as just magnitude, whereas velocity is defined as magnitude or direction. Velocity is also described as speed and direction. Like the key word is direction is always there. So if the direction is there, it's velocity. Here's a little chart of the different types of Doppler. So it's very, very condensed. As you can see, there's really no explanation, but what I like about it is just the simplicity. So for example, if the test is talking about range ambiguity, immediately your brain should go to continuous wave Doppler. If if the test is talking about range resolution, range accuracy, it's talking about pulse wave. This one uses a small sample volume at a specific depth. This one has a large region of overlap that does not cause aliasing, whereas pulse wave Doppler does. So I just liked this kind of all of these ideas being brought together in a diagram. Okay, next, they're going to show you a picture that looks like this. And they're going to ask you, what is the direction of flow? So they might say, what is the direction of flow in the top vessel or the bottom vessel? So first of all, you want to make some quick, point out some things about it. So here, make sure you're looking at the color map. You could see that red represents the towards color and blue represents the away, simply because of their location on the color scheme. This is, one vessel here. This is another vessel here. And, fair warning, the pictures that I've experienced or that other students have experienced haven't been that great. On top of that, you want to make note that this is taken with a sector transducer. I can tell that because of the shape of my color box. It's a sector transducer. We know we can't steer these boxes. They are how they are. And then you also want to make note that this is the right side of the screen and this is the left side of the screen. I added the right and left there. Obviously they weren't there and they're not going to be there for you on your picture. So you just got to make sure that that is the right side of the screen and that is the left side of the screen. So how to determine the direction of flow when using a sector transducer, and here are the steps. So first, step number 1, identify the towards color on the color map. So if we go back to our towards color, in this case, the towards color is red. Number 2, identify the away color on the color map. Without having to look at the picture, it's blue. And number 3, place your finger on the vessel's towards color and slide it away. Okay, let's try it with that bottom vessel. So we're going to put our fingers on the towards color. What's the towards color? The towards color is red. How do I know that? Because any color on the top of the color map is the towards color. So in this case, the towards color is the red. So I'm going to put my color on the towards color. And I'm going to slide my finger away. Notice what direction I was sliding my finger. I was sliding my finger from right to left. and that is the direction of flow in a sector transducer. Maybe they say, what's the direction of flow in a sector transducer? But now let's use the top example. So again, you're following the same 1, 2, 3 steps every time. Put your finger on the towards color and slide it away. And so in the top vessel, my finger slid from left to right. Okay, next, how to determine the direction of flow when using a linear transducer. So this time we're talking about a linear instead of a sector. Let's follow the steps. So steps, number 1, look at the 2 top corners of your color box. Okay, so we're going to look at this corner and we're going to look at this corner. Then it says, draw a line extending downwards from the corner that does not run into the color. If I draw a line coming down from this corner, that line would have to pass through the color. Therefore, I'm going to draw a line extending down from this corner because that line will not run through the color. Number 3, this is called your home line. Okay, so that line is now called my home line. Identify if the vessel represents towards or away color. Okay, so let's look at the vessel, and I don't have a color map here, so I'm going to give myself one just for the under. So I'm going to put red on the top and blue on the bottom. So when I look at this vessel is red. Red is my towards color. So let's see what it says next. Slide your finger across the vessel, either sliding towards your home or away from your home, depending on the color map. So if this vessel is red, I just have to look on my color map and determine what red is. In this case, red is on the top of my color scheme, so red represents the towards color. So therefore, I'm going to slide my fingers towards my home line. If I'm sliding my finger towards my home line, again, this is the right side of my screen and this is the left. The flow is going from the right side of my screen to the left simply because I'm going towards my home line. Now, if I cross this out and I had a different one, I had where I had blue on the top and red on the bottom, and I look at this vessel, this is red. Red is my away color. So slide your finger away from your home. So if you're sliding your finger from left to right, because you're going away from your home. So you're either sliding your finger towards your home, that line, or away from your home, that line, depending on what color the vessel is and whether that color is a towards color or an away color. Go ahead and watch this a few more times just to make sure you got it for the test. Here's another diagram that I want you to pause and look over and read carefully. Anything with this has all 4 of the Doppler modalities side by side for comparison, which is really nice. If they show you a picture that looks like this, so in both of those bottom pictures, there's just too much color. That is called confetti, and that occurs when you have too much high gain. So your gain is too high. This artifact is an artifact that we see on spectral Doppler display, and it is called snow, and it also occurs when you have very high gain. This image is showing you an example of a button that's being used. If you look at it carefully, the only thing that's being erased are the echoes that are immediately around the baseline. Therefore, which button is being used to eliminate those lower frequency echoes that are around the baseline from A to B? So if you said high pass filter, you are correct. Wall thump filter. Here are two more examples of what they can show you. In this first example, why is there no color in this vessel? There could be several things that they tell you. They could say like, should you increase the gain? Yeah. Should you change your scale? Probably. Should you steer your color box? Most definitely. So, although all of those would be correct, what's the first thing that you noticed as being the thing that caught your eye as being very wrong? It's the steer of your color box. So, the steer of your color box is if you can't see it, the steer is not parallel with the direction of flow. What's wrong with this vessel? Again, they could say, should you increase your gain? Yeah. Should you change your scale? Probably. Should you just steer your box the right way? Yeah. What's the problem here? Your vessel's a little bit too straight, but your color box is also straight, and so you kind of have to look and determine what is the most wrong thing, because more than one button can be used to manipulate an image. So you don't want to get out of hand and say, I would change 15 different buttons versus look for the thing that your eyes identify as like, hey, I caught this. This is a really wrong thing. And this is my answer. I wanted you guys to look at a picture of this and tell me, is this considered color aliasing? So hopefully you answered no, because if you look at the way the colors are shifting, you have red, you have a thin line of black, and then you have blue. Exactly as it is on this part of the color map. You have red, a thin line of black, and then blue. That's flow reversal and not color aliasing. Color aliasing would show a mixture of colors that are located at the color bar extremes. So it would be the yellow mixed in with this color. I'm not sure what color that is. It would be those colors instead of the pattern of red, a thin black line, and blue, which represents flow reversal. Wrapping it up here, something that is on the SPI and they're going to ask you about the dead zone. And so, what is the dead zone? The dead zone is a region on your image. So, when you're looking at the dead zone on the image, it's the very, very, very top of the screen is called the dead zone. The reason it's called the dead zone is because it says anything that's superficial or at a very shallow depth that's within this region will not be imaged accurately. So anything very superficial that's within the dead zone will not be accurate when you look at it. So, for example, sometimes patients come in with an abscess, right? So, an abscess is like sometimes it's very, very superficial. Like, literally, there's like, blood and fluid and pus coming out of the patient's skin because, like, this abscess is so superficial. Well, if I'm looking at the ultrasound machine, or I'm sorry, at the ultrasound display, sometimes the abscess, because it's so superficial, I would see it somewhere up there. Again, that's the dead zone. The dead zone is just the most superficial part of the image. So if this abscess were located a little bit lower, or even deeper, it would be outside of the dead zone, which would make it more accurate to image. So because this structure that we're looking at is so superficial, we have to find a way of pushing it down and not having it so superficial on the screen. So what we're going to use is we're going to use a standoff pad. Let me show you what that is. So here's an example of a standoff pad. So what a standoff pad is, it's just a round or rectangular pad made out of like a gel consistency. And so what we do is we put gel under it, we put gel over it, and we slide our transducer over it. And let me show you what it does to the screen. So here's one example of how in that first picture in figure 3A, you have a linear structure and it's very, very close to the top. Yes, you can see it, but it is a little bit challenging to see. On the second image, 3B, Just the fact that it's pushed a little bit lower, and yeah, maybe they also changed their gain a little bit, but the idea is that it's out of the dead zone and now it's imaged with more accuracy. Here's another example. So here in image A, whatever that rounded structure is, it's very close to the top, kind of making its borders a little bit harder to identify. With image B, see how the very, very top of the screen goes black? When the top of your screen goes black like that, it's because you're using a standoff pad. And so make sure you know that when the top looks black like that, it's because they're using a standoff pad, and it pushed that rounded structure a little bit lower, and then you can see it a little bit easier. You might also notice the guy that looks like he's scanning a glove. So they're just showing you that standoff pads are pretty easy to make. You can literally just take a glove, fill it with water, tie the end up so that it doesn't, leak all over the patient. And again, you're going to sandwich the standoff pad or your fake standoff pad that you just filled a glove with water, but you're going to put gel under it and gel over it and scan through it. And so standoff pads you can even make if you work somewhere where you don't where they don't have one. And then if there is an increase in the dead zone, so it just happens to be larger than what I guess is typical, it could be that there's a cracked crystal or detached backing material. So that's something you just have to memorize as far as the dead zone. And then here's some definitions that we've been seeing more and more on the SPI. So you have to understand what respect for autonomy is. You have to understand what non-maleficence is, beneficence, and justice. And so you want to read through these definitions and make sure that you guys know them. They might show up on your SPI, maybe not, but they do ask a lot of questions as far as like our interaction with patients to make sure that we are practicing with care. So the last thing I want to say is that you guys have a lot of study material now. You have your books, you have your notes, you have your flashcards, you have your lists, I'm confident that many of you guys have external resources and programs and so on that you have purchased. Um, the point is to put yourself in as much physics as possible, but also being wise to where you're not overwhelming yourself. If you are becoming overwhelmed and you kind of can't see straight anymore because you feel like now you have too many resources, then it's time to go back to basics. And the basic is your book. Okay. And so, and if you don't feel overwhelmed and you feel like, you've been studying and you can, every day you can kind of do something a little different and use one of your different tools, like maybe on Mondays, I like my book. On Tuesdays, I like my notes. On Thursdays, I like the games on my phone and, all these things, then that's okay too. But you have to be the one that knows, right? And just because your friend or your classmates are doing something doesn't necessarily mean it's going to work for you. So you got to be able, you recognize your own stress levels and your own abilities better than anybody else. And so just be mindful every single day you study. And you just do it until the day of your test. And then the day of your test, you're going to do your best. And that's all you can do. And you're going to try to put together all the information, right? You're going to have your hards list and you're going to get there early and you're going to study your hards list in the car and you're going to brain dump on your paper before your test, and you're going to focus on one test question at a time and no more. And at the end, you're not going to go back and change questions or answers, and think of all the things we've talked about and we've learned together. So reflect on it, but not just reflect like, oh yes, I remember you told me not to change test answers, but I'm still going to do it, because that's no good. You got to use all those tools now. Okay, so I believe in you. I hope that you study and that you are successful. Thank you again for your time with physics, and I'll talk to you later.